Friends, welcome to our Wednesday CME. Before I introduce Dr. Pravas Mishra to you, I'd like to introduce our group to Dr. Mishra. Sir, this is a group of top elite 50 or doctors of South Delhi. This is the Physicians Forum of India, which is a registered body today. And we've been having this CME every Wednesday over the past 10 years. This is the first CME we are having with you, and we hope to have many more with you. Since you are a hematologist, we'll have to have much more. Okay, friends, so Dr. Pravas Mishra, he's completed his MD Medicine from Sevagram, Varda, followed by MDM in Hemato-Oncology from AIMS, New Delhi. He was a faculty at AIMS for past 15 years, which he left just about a month back, and where he established the transplant program. He was the professor of hematology and the director of Hemato-Oncology and PMT. Now, he is the director of Hemato-Oncology and PMT at Max Hospital, Patparganj and Vaishali. His special interest is haploidentical transplant, which is half-match transplant in leukemias. And to his credit, he has more than 300 BMTs to date.
Century.
Welcome, sir. All yours.
Thank you, Dr. Tulsi. No, this is fine. Alright. No, this is alright. So, I was here, as some of you recollect, a couple of weeks back, when Dr. Mitu was giving the talk. And once again, thank you for inviting me over. And I really look forward to having more of such CMEs in this forum. So last time I was asked that I should be speaking on bone marrow transplant, and it is a subject which is very dear to my heart. And so today we will be speaking about bone marrow transplant. So I am the director of hematology, hemato-oncology and transplant program at Max Hospitals, Patparganj and Vaishali. So that is where the transplant unit has been developed, and currently it is in the Max Hospitals at Patparganj, and we are now planning a bigger unit in Vaishali, and in due course of time we will be shifting there. So they are close to each other. So BMT is something which very few of my colleagues, when I was at AIMS, even at AIMS, there are very few people who would actually understand what we were doing. People understand kidney transplant, people understand liver transplant. But the moment we start talking about bone marrow transplant, there is a blank look. Ki hota kya hai? So exactly what is bone marrow transplant? Like BMT is called bone marrow transplant. So at the very simple definition would be that you replace abnormal cells with normal cells. Abnormal blood cells with normal blood cells. So that is bone marrow transplant. Now, essentially this is stem cell therapy, and this is the only true form of stem cell therapy that is currently available anywhere in the world. So when we talk of stem cell therapy, the origin is bone marrow transplant. So you take the immature stem cells from the bone marrow, you draw them with a needle, and then you inject them into somebody who has either some kind of a congenital hematological problem or a leukemia, and try to replace those abnormal cells with the normal cells from the donor. So these are stem cells. So how does this differ from all those other applications of stem cell therapy that you are now listening about? So most of the stem cell therapy that you are listening to, what you are reading to, there's all hyped up. So for several years, several decades, now people are talking about stem cell therapy. People claim that they can replace abnormal cardiac muscles. So people say that they can, cure cerebral palsy in small children. People claim that they can even cure any kind of neurological problems. So there was a lot of debate. There is a lot of literature also on the use of stem cells, anecdotal reports of improvement in various of these conditions. However, none of the long-term or prospective trials could actually prove it. In fact, in AIMS, All India Institute of Medical Sciences, some of you might have heard of ORGO, that is the Organ Retrieval and Banking Organization. So there an entire unit was set up simply for this purpose. In fact, the stem cell unit was set up just so that they can collect stem cells and start doing all that great work, because of so much hype was there at that time. Both cardiology department and neurology department started using stem cells. This has been now almost 10 years. Even now, if you talk to any cardiologist or neurologist at AIIMS, they will tell you it has not actually worked. So stem cell therapy, when they talk about this, is all experimental. People are doing experimental work. And what we are aiming, I think in Gautam Nagar here next to AIIMS also people are doing stem cell therapy. So one should be very careful of what people are talking about. This is a paper which had come in New England Journal of Medicine just recently, and somebody was trying to inject stem cells into the eyes or something to improve macular degeneration, and the person lost their sight. And this was a small case, and this came to the NEGM just to highlight the fact that stem cell therapy should be done under very controlled situation, under a very controlled scientific rigor, and not just anybody can just start taking some stem cells from somewhere and do unregulated work. So stem cell therapy, remember, it is only bone marrow transplant. Now when I talk of bone marrow transplant, we used to call it bone marrow transplant because the first transplant that was done using bone marrows. And in fact, I would like to tell you that there are only two medical procedures that have got a Nobel Prize. One is the transplant and other is IVF, in vitro fertilization. So these are the only two procedures that have got a Nobel Prize. Transplant, both the bone marrow transplant and renal transplant, both of them shared the Nobel Prize in 1990. So that time they were using bone marrows, but now we can also use stem cells from the peripheral blood. And in fact, most of my transplants, most of the 300 odd transplants that I have done, nearly 80% of them have been done with stem cells from the peripheral blood. So we do not actually start using bone marrow stem cells. We can also use stem cells from various sources. So what are the sources? Bone marrow, of course, is one of them. Bone marrow as a stem cell source we are using mostly for small children who have got very small donors for congenital problems like thalassemia or sickle cell anemia. Because bone marrow stem cells, there is less of graft versus host disease, and that is why we like to use bone marrow stem cells in these conditions. Peripheral blood also can be a source of stem cells. As a routine, the peripheral blood will not have stem cells. Those stem cells are not circulating in the peripheral blood. So what we do is that we give growth factors. You must have heard of GCSF, Grafil, Grastem. Whenever the TLC or the counts are low, people inject it. So these stem cells, these growth factors are injected into normal individuals, the normal donor who is matched with the patient. And when this is injected into those normal donors, the TLC, the total leukocyte count starts to increase. How does it start to increase? Basically what the growth factor does, it acts like a scissor. It has got, it's like a scissor-like effect, where it goes into the bone marrow and cuts the connection between the stem cells and the bone marrow environment. So the stem cells start floating into the peripheral blood. This is a very crude way of putting, but this is exactly how it happens. And the stem cells start coming into the peripheral blood. And once the TLC is increased, we can use apheresis by centrifuge machines, and then we start collecting the stem cells and we can inject them. So peripheral blood is the source of stem cells for most of the transplants that are now taking place all over the world. Cord blood, of course, is a very important source. So you have now started hearing a lot about cord blood banking. You must have, there's a life cell is there. And I recently had I was talking on bone marrow transplant again at another August forum of physicians, and there I was very adamant that this cord blood transplant banking program is completely useless. So essentially what they are doing is that they are telling the family members that your cord blood might be useful for you at some later date, and then they are collecting those cord blood and then they are transporting them. However, you must understand that your own child's cord blood is never going to be useful for that child. If that child has a congenital inborn problem, that cord blood is not going to be of any use for that child. Even for that matter, 10 years down the line, if unluckily that child has a leukemia, again that cord blood is not going to be of any use. It is essentially as good as your autologous bone marrow, So that is not going to cure you. So what LifeCell and other people are now doing is that I think they have started something called a community banking. So you might have heard of it. So what they are doing is that they are asking a group of people, like you are all a society, right? So each of you donates your cord blood into the pool. And for the next 2 years, that cord blood is yours. And then after 2 years, it becomes part of the community. So if anybody in your family needs a cord blood, then that whole pool is available. So I think it is a kind of a public banking which is being funded by the people who are joining it. It's kind of a society kind of thing. I don't understand it completely, but this is what they actually mean. But even then, much of it is hyped. Much of it is hyped because they are again saying the same thing, that cord blood is a good source of stem cells, and this stem cell can cure your neurological problems, it can cure your diabetes, it can cure somebody's macular degeneration, which currently is still experimental. People do not know whether that actually works. And cord blood as a source of stem cell is currently useful only for hematological problems alone. So how many of the people will be having hematological problems? So what is the chance that you would actually require your own cord blood? Or even in that small community bank of life cell, how many of those people will actually need the cord blood? So that is why it is a bit of a hype. So these are the sources of stem cells that we use when we are treating hematological disorders. So bone marrow aspirate is just done, some of you might have done bone marrow aspirate during your training program, and this is exactly how it is done. We just put a needle in the posterior superior iliac spine and we aspirate the bone marrow. So when you do a bone marrow examination, you just take about 10 ml, 5 to 10 ml of bone marrow. However, when we are doing a stem cell transplant, using bone marrow, we have to aspirate nearly 300 ml. For example, if there is a 60 kg person, I might need to even aspirate as much as 500 to 600 ml of bone marrow. And aspirating bone marrow is a very painful thing for the patient. Putting the needle into the bone marrow doesn't pain that much. Moment you put the syringe and you aspirate, the patient says, I have never faced such a pain ever in my life. So this has to be done under general anesthesia, whatever the age of the donor. Definitely small children, even elder people have to go under anesthesia. This is a photograph of one of the things. So both of us are sitting on either side of the patient, and we are aspirating from the posterior superior iliac spine. So this is how a bone marrow harvest is done, and the bone marrow is collected into a normal blood bag. So you might be curious as to where we are actually collecting it. We just go to the blood bank and we say, you give us your routine bag. And if we have to collect say 600 ml, we take 2 bags. So because each bag will have just a capacity of 300 ml. Yes, sir.
What size needle?
Needle 16 gauge. So the bag that is used is a routine blood bag that we are using, the triple bag. So that once the bag is collected, in case we have to centrifuge and separate the, sometimes there is a red blood group mismatch. As such, for stem cell transplant, we are not really bothered about blood group mismatch. But if you are using bone marrow, sometimes the amount of blood in the, say, somebody has a hemoglobin of 16, so hematocrit is, 3 times, 48%. So 48% of 300 ml, 600 ml could be a tidy amount of red blood. And if that we are going to inject into somebody who has got a different blood group, could be a problem. So only in such cases, we need to then centrifuge and remove the red blood cells to some extent. When we are doing peripheral blood stem cell, I'll show you what a apheresis machine looks like. In that case, the apheresis machine itself will be only separating the white blood cells. We hardly have 10 or 12 ml of red blood cells in that bag. So then it is not a problem. So this is a picture of how bone marrow harvest is done, and this is how, on the other hand, a peripheral blood stem cell harvest is done. You can see a donor looking very happy and smiling. So what we do is we give them injection growth factors for 4 days, and on the 5th day we hook them up to an apheresis machine. So this apheresis machine, many companies are making it. There are Fresenius, Scope, Spectra, Baxter. So these are the companies which are making these stem cell apheresis machines. During dengue season, many of these such machines have been bought by the Delhi government for, during the dengue season. Several years back, I remember many hospitals got apheresis machines. Those apheresis machines were used to collect platelets. So, but anyway, platelets are not much useful in dengue. That's a different matter altogether. But it is the same machine that we are using for collecting stem cells as well. So there is just a word, somebody in this country needs a stem cell and they don't have it within their family. They will connect with this bank, and they will just simply run that HLA and see if it matches with any potential donor. And once the donor is matched, then they contact the donor and ask them, would you be willing? If they say yes, then the whole process starts. So this is what a stem cell registry does, and that is an unrelated donor. And then finally we have got the cord blood, which I talked to you about earlier in some detail. So for the transplant procedure, obviously the first thing is that there has to be a condition which needs a transplant. I'll come to that later. So the first thing that once you have identified that a person needs a transplant is that you have to do HLA matching. And this HLA matching is a genetic test, so it has got both class 1 and class 2, you might have heard of those. For a sibling transplant, that is when you want to do a matching from either your brother or your sister, you need to do just 6 antigen match. 6 antigen match का क्या मतलब है? So for example, I have just kept this one example here. So you, for a 6 antigen match, you only do A, B and DR. So three loci, and each of these loci have got 2 haplotypes. So A and B, each, we have got 2, all of us. So everything is 2. So 1, 2, 3, each of them has got 2, so that is 6. So you have to match at 6 antigens. So if 2 people are matched at 6 antigens, it means it is a 6 by 6 match. And this is sufficient for doing a transplant as far as brothers and sisters are concerned. So this is called a low resolution matching. Then there is something called high resolution matching, in which you start seeing even more degrees of mismatch. And that is required whenever you are doing any transplant from anybody who is not your brother or the sister. For example, this is the example of somebody who had matched with his, who was I was talking haploidentical transplant. So if somebody is completely matched, it is called 6 by 6. And if somebody is not matched, so you can have a 5 by 6 match, you can have a 4 by 6 match. Then you do more matching. So you start looking at C, you also do DQ. So 1, 2, 3, 4, 5, it's 10 antigens. So then you start looking at 10 antigen match. So somebody might be 9 by 10 match, then you can take that. And now my specialty is doing half match. That means somebody is just 5 by 10. So this is a patient who had got acute myeloid leukemia with relapse. He was transplanted from stem cells collected from his father. So obviously all of us will be half matched with either of our parents. So this was, if you look at this person shares 33 here, 44 here, 7, 7 and 2. And the rest of the line, the lower line, is completely different. So this is just half match. So there are various ways of even choosing a donor. Not all half match donors can be taken up for transplant. So for example, this father was a good candidate because he was homozygous. Like for example, that is 2 haplotypes. You can detect here. He is 33 here and 33 here. If you look at the patient, he is 33 and 11. This is what most of us have. But sometimes at some loci, we might be homozygous. We might be homozygous like this. If you are homozygous like this, if the donor is homozygous, then the chances of GVHD increases. But if the same thing had happened with the patient, then there is a risk of rejecting the graft. So if you have a patient who has got homozygous at some loci, then I am very terrified, because then I cannot take any donor, because any donor he takes, that donor he will reject. And there is a very high risk of rejection with a half match transplant. So this is how we start to choose a patient for a transplant. So once we have identified both the patient and the donor, we have to now see whether the patient is fit for the transplant or not. Even though the transplant is essentially a medical procedure, it is no less than any surgery, than a major surgery. It looks like just medicine, but the person has to be fit. So we are very afraid of comorbid conditions. For example, if it is an elderly person, so then in that case we have to look whether this person has had uncontrolled diabetes, whether that person has any underlying renal dysfunction, any underlying liver dysfunction, or then of course viral markers. So hepatitis B, HIV, anti-HCV, these are all looked at. Now one thing about hepatitis B and hepatitis C. If somebody has got hepatitis C, that is not so much of a contraindication for doing transplant, unless that person has developed cirrhosis of the liver. If somebody has got hepatitis C and HCV RNA is say even 50,000, 1 lakh, it does not matter, because for example, if that person has got leukemia or aplastic anemia, it is more likely that he is going to die of his disease than of the hepatitis C, because the hepatitis C will be causing liver dysfunction or cirrhosis or hepatocellular carcinoma down the line. So we can first transplant the patient and very happily treat the person once the transplant is over for his hepatitis C. So hepatitis C is not a contraindication. Particularly this is important for aplastic anemia and thalassemia who have got multiple blood transfusions. So many of my patients, when they come for the transplant, aplastic or thalassemics, they are already got hepatitis C. So that is not a contraindication. Unfortunately for hepatitis B, that is a problem, because hepatitis B is a different virus altogether. The moment the person's immunity is down, it will suddenly flare up and person can have a fulminant hepatic failure. So if somebody has got hepatitis B, I look at the hepatitis B DNA, and if that is raised, then we first have to manage hepatitis B. Once that is controlled, only then we can take up the person for the transplant. Dental, very important. We send them to the dentist, and then he looks and he says there is a caries tooth that has to be removed before the transplant. Even if that person is aplastic anemia, I would give them platelet SDP or single donor platelet or random donor platelet and get that teeth uprooted. Because once the transplant procedure is started, that will become a source for sepsis. After the transplant, for the next 6 months to 1 year, the person will be immunocompromised. In any dental procedure, even in routine people also, it can cause bacteremia. And so you can think about what has happened to a transplant patient. So transplant patients, either a child or an adult, has to undergo a very good dental examination prior to the transplant and get any bad teeth out. Psychiatry, of course, is important because the psychiatrist would evaluate the patient, not just the patient, also the family. Whether they have been told about the transplant, what do they understand about the transplant, because it can be a it is a high risk procedure. So they have to understand independently whether the patient and the family have understood the pros and cons of the transplant. So we actually talk to 1 or 2 psychiatrists, explain the whole procedure to them, because not everybody knows about this. And then they are better able to analyze our patients. Otherwise we send to the psychiatrist and say, simply fit hai. That doesn't work. Kidney creatinine clearance is important, particularly when you're using certain drugs like cyclophosphamide, busulfan. They have got renal clearance. So if you don't have a very good renal clearance, you will be increasing the toxicity. So we will do sometimes glomerular filtration rate from the nuclear medicine. Liver function test, pulmonary function test again is very important, because even after the transplant, people can develop pulmonary complications. Even GVHD can rarely affect the lungs. And then people can get lung infections, they can get fungal pneumonias when they're neutropenic during the transplant period. And if they already have a compromised lung, then the chances of dying increases. We have to do an echo. Any patient who is planned for a transplant, we have to do echo. One would be surprised at the number of times that we find somebody has had an undiagnosed cardiac problem. And they are not at all symptomatic for it. It is very important. All of these are very important when we are doing the transplant. Any comorbidity, in fact just 1 or 2 comorbidities like a cardiac problem or a renal problem can increase the risk of mortality from transplant to as high as 20 to 40%. So for a normal transplant, moment we say if 10% mortality is actually very high. Moment you have got a comorbidity, either a renal problem or a cardiac problem, such a patient is at an extremely high risk for transplant, and I would not take that person for a transplant. Blood group I have put here. Again, it is not important per se. It is not a contraindication that somebody is A and the other is B, so it is a problem. No, it is not a barrier for transplant as far as the blood or marrow transplant is concerned. Except for the marrow, sometimes we have to deplete. We have to remove the red blood cells to some extent by using a centrifuge in the blood bank. For a peripheral blood stem cell transplant, the apheresis machine itself takes care of that problem. So when it is centrifuging, it sorts out the red blood cells and sends it back to the donor. So I don't know if any of you here is a blood bank specialist, but they would be better able to explain this whole process. So this is how we screen both the patient and the donor for fitness prior to doing a transplant. Then we have to ensure that there is a good venous access. So we place something called a Hickman catheter. Now this Hickman catheter is essentially a tunneled catheter. So as you can see here, this is the catheter. It goes into the skin here and it goes through into the heart. So there is one more connection here. So what we do is that we insert, you have got these triple lumen lines which you put in the internal jugular vein. So you use the ultrasound guidance and we put in a guide wire from this point. Then another operator cuts from here and puts in the catheter here. So there is a big area of skin, subcutaneous skin. So the site of entry and the actual site where the catheter is different. So there is a tunnel here. It is under the skin. So this is called tunneled catheters. The advantage of this over the routine catheters is that they can be placed there for a very long period of time, almost 6 months, 4 to 6 months you can leave this catheter there, and it is very safe and the person is very comfortable. Any blood investigation that we need to do can be done from there. Any kind of medication that we need to give can also be given through this. The person need not be pricked again and again. So this is particularly important because during the transplant period, lot of fluids are being given, lot of electrolytes need to be checked. So every time some potassium is going, sometimes some saline is going, some antibiotic is being going on, some kind of blood support is going on, platelet or blood. So this kind of ports are very important during the transplant program, and we need to have this in place before starting the transplant. And then it comes to the transplant. So what is the transplant? We have collected the stem cells from the donor. So it does not mean that we now just simply take those stem cells and infuse in the donor. The donor has to be first prepared for the transplant. So how do we prepare? So basically, when I explain to the patient, I tell them that कि आपका bone marrow को खोखला कर दिया जाएगा. आपका bone marrow को खोखला कर दिया जाएगा और वो घर बन जाएगा वहाँ पे दूसरा stem cell आने के लिए. So this is a very crude way, but actually the actual thing that we do. So we give chemotherapy. So we give chemotherapy prior to the transplant, and we give very high doses of chemotherapy. We give such high doses of chemotherapy that there is no possibility that the bone marrow can actually recover on their own. You might have heard of chemotherapy being given for cancers and various other malignancies, and then the person's counts fall down, and after giving growth factors, bothered about ablating the marrow. Marrow is already empty. So we immunosuppress the person, and fludarabine to some extent also causes myelosuppression. Then we have got reduced intensity. Like for example, we also transplant people who are 62, 65 years of age, but they will not be able to tolerate the full doses of conditioning regimen. Like if you give them the complete myeloablative thing, they might not tolerate it. Their gut might not tolerate it. There will be severe mucositis, and they might have pneumonia, they might have some kind of infection, and they might die. So what we do is that we give them reduced intensity, half and half. A little bit of myeloablation and a little bit of immunosuppression. The disadvantage of a reduced intensity has been that there would be a little more chances of relapse because you have not completely ablated the marrow, particularly for cancers. However, at least in the older person, this is a way that you can actually have this person survive the transplant process. And then, so all of this, as I written here, they depend upon the indication and the patient fitness. So if you have got somebody like a thalassemia or a leukemia, then it is good that you should do a myeloablative kind of a regimen. If you have got somebody whose marrow is already empty, then you give an immunosuppressive agent, or you give a non-myeloablative kind of a regimen. And if you have got somebody who is very old, who is already very fragile, but needs a transplant, you use something called a reduced intensity kind of a regimen. So this is GVHD, or graft versus host disease. So to prevent the graft versus host disease or to reduce that risk, we give certain drugs. We give drugs such as cyclosporin and methotrexate. So these are the drugs which are required to prevent graft versus host disease and also to avoid the rejection of the graft by the patient who has received it. So important components, first is the conditioning, then the stem cell collection, infusion of the stem cells, and then we have to give them some kind of a graft versus host disease prophylaxis. And this can, and unlike for example a kidney transplant or a liver transplant where it could be lifelong, in bone marrow transplant this prophylaxis, so that the person does not reject that graft or that graft does not act against the person, lasts from 3 months to 1 year. For malignancies it is 3 months, for other bone marrow failure syndromes and for thalassemics it lasts a transplant. That is my area of interest. So how we have started to do haploidentical transplant is by a very elegant procedure called post-transplant immunosuppression. So what we do is that when we are giving stem cells into the person, both the that donor stem cells and the recipient the donor's T cells and the recipient's T cells, they start reacting against each other, and both the T cells will start proliferating. And that is how the T cells of the donor will proliferate, and they will try to reject the stem cells of the donor, and the donor's T cells will proliferate and they will try to reject or act against the recipient's body. So this process starts the day you start to infuse the stem cells, and it peaks at the 3rd day. So what we do on the third day, we give a dose of cyclophosphamide, and this cyclophosphamide knocks out whatever T cells have started to proliferate, and that is how we are now able to do haploidentical transplant. And in addition to that cyclophosphamide, we also give something called mycophenolate, mofetil, Celcept and tacrolimus. For a period of 30 days we give Celcept or mycophenolate, and for the next 6 months we give tacrolimus, which is essentially one of the same group of drugs like cyclosporin and sirolimus. Again, these are immunosuppressive agents. So this is the GVHD prophylaxis that we give to our patients. And then the other important prophylaxis that we need to give patients are for infection. Like all of these patients are extremely prone for infection. So the first thing that we try to do is that we do the transplant within a special room called a HEPA filter room. So these are air conditioned rooms which have got a filter which is placed on the air condition. In addition to this, these have got pressure support within the rooms itself. Air keeps getting changed within the room at a certain speed. So the moment you try to enter that room, you will feel the gust of air which comes and blasts against your face. So basically the air inside is forced into the room and it exits. So the outside air does not come into the room. So the air is forced into the room, it goes into there is a differential pressure. Room to the bathroom to the outside. Again room, there is an ant room, and then from the ant room into the corridor to the outside of the transplant unit. So at no point of time outside air is getting into the patient's area. So this prevents the incidence of any kind of fungal infection, which is a big major killer for transplants. Having said that, I must tell you, all the 300 transplants that I did at AIIMS was in a non-HEPA filtered room. In fact, we used to do it in any available private ward room. So we could have a transplant and there could be an orthopedic patient next door. There could be a patient who had just delivered a baby last night in the other room. So we have done transplants in that way also with pretty good success. But of course, we had to have a lot of support both from the nursing staff and from the patient's relatives to understand that they just simply can't walk in and out of the room anytime that they wanted. So HEPA filtered rooms, important to prevent fungal infection. Even so, candida infection is it could be a big killer. So we give fluconazole prophylaxis. Then bacterial prophylaxis we give levofloxacin. Then for herpes we give acyclovir. For PCP, that is pneumocystis carinii, we give Septran. And for post-transplant, like once the transplant has been done, one of the major important viruses that we face are cytomegalovirus. Now, one thing about cytomegalovirus, all of us here are positive for that. Everybody in India is cytomegalovirus positive. I have yet to come across anyone who is cytomegalovirus IgG negative. All of us are IgG positive. Something like tuberculosis. We are all infected, but we are not diseased. Moment our immunity comes down, we will get tuberculosis. It is called tuberculosis reactivation. Similarly, cytomegalovirus can get reactivated. And once it gets reactivated, it is a very dangerous situation for everybody concerned. So we do, once a person is transplanted, every week or every 2 weeks, we send for the CMV PCR, not just PCR, because PCR will always be positive, we are all positive, we do quantitative. So moment it crosses 500 copies per microliter, we start to treat this person with ganciclovir as a preemptive measure. Because if we don't do that, the cytomegalovirus can do certain things. It can cause rejection of the graft. It can cause pneumonia. It can cause diarrhea. These are just the few things that it can cause. And all of these, once the person has developed them, then it is almost always fatal. It's very difficult to manage these cases. So, post-transplant, we have to do cytomegalovirus monitoring at regular intervals. Once all the immunosuppression is over, so we are not just ablating the marrow, we are also destroying the person's immunity. B cells, T cells, these are all destroyed. And once the transplant is done, the B and the T cells will now start to proliferate again. And these are the donors B and T cells. Now they are new T cells, they are new B cells, and now they are learning about life all over again. So that is why we have to vaccinate this person like we vaccinate any child. Except for the BCG, we start from TT, we do DPT, and then we go on to measles, rubella, everything, right from the beginning. So it's like a rebirth. So it could be of any age. It could be a 55-year-old who has undergone an allogenic bone marrow or a peripheral blood stem cell transplant. That person has to undergo a vaccination. So you might be curious how we infuse the stem cells. Very simple. We just infuse the stem cells like any other blood product. We just hang it and that is infused into the blood. So what are the diseases covered? So we cover almost all hematological malignancies and benign disorders, particularly thalassemics, sickle cell anemia, leukemias, lymphomas and myelomas. We also do immunodeficiency disorders, several other such disorders are there. Cost issues. So usually unless somebody has got any major infections, if it is an infection or a GVHD, we are able to do an allogenic transplant within 10 to 15 lakhs. And if we are doing an autologous transplant for either a myeloma or a lymphoma, we can do it for under 8 lakhs. It is an expensive procedure, but all the same, we are able to do this at very economic terms as compared to anywhere else in the world. Then the other last question that people ask is how successful is the transplant? Now this is a question which is heterogeneous. It depends from indication to indication. For example, even within thalassemia, if somebody is a 7-year-old, the chances of a success for that person, and if he's been well chelated, is 85 to 90%. Even among a thalassemic, somebody who is 17 years old, has got a hepatomegaly, has got fibrosis, and if you're trying to transplant, the chances of survival could be as low as 57%. So within the same disease, different kind of people, the transplant success rates are different. For aplastic anemia, 75%. But if you're taking myelofibrosis, a very bad disease, the chances of good outcome after transplant is not more than 50 to 55%. So the success of transplant differs from indication to indication. Again, from when we say autologous transplant, most of the time the aim of autologous transplant is progression-free survival. Means we just simply want to suppress the disease for as much as possible. And if you're doing an allogenic transplant, usually the aim is cure. So this is what a transplant unit looks like, and this is my phone number and my email. I'll be happy to take any questions. Thank you.
It's a unique opportunity, I'm telling you, to have this CME. So please ask questions.
Yeah, Dr. Mishra, that was such a nice talk. So, you said...
Do not engraft very quickly. They take some time to engraft. And particularly in our kind of scenario where a person is very sick, the risk of infection is very high if the duration of neutropenia gets prolonged. So peripheral blood stem cells, they engraft quicker. And the risk of relapse after, like the rejection is also high with the bone marrow stem cells. Hence, we prefer to use peripheral blood stem cells now.
So what would be the indications of bone marrow transplant?
So you mean against peripheral blood stem cell transplant?
No, just transplant.
So any blood or marrow transplant, whenever we are talking about, it would be, so as far as I am concerned, it would be any hematological condition which requires a transplant. For example, in children it could be a thalassemia, it could be sickle cell anemia, it could be marrow-filial syndromes like aplastic anemia, it could be malignant conditions or pre-malignant conditions like myelodysplastic syndrome going on to leukemias. Now, leukemias, sir, I must tell you that all childhood leukemias need not be transplanted. They can actually be managed by chemotherapy alone, even for adults also. However, certain, for example, in adults, acute myeloid leukemia, we would advise a transplant to almost all of them except for a certain subgroup. We can also do transplant for non-hematological conditions. And one important condition that we have started to do transplants are in multiple sclerosis.
So, would you say refractory leukemias, refractory lymphomas, multiple myelomas?
Yes. So, to that, for myelomas and lymphomas, we are using autologous transplant. So, whenever there is a myeloma or lymphoma, these people, we don't do allogenic transplant because the risk of mortality is very high. Even today, anywhere in the world, most people will not do allogenic transplant for myelomas or lymphomas who have relapsed. But we will do autologous transplant at relapse. First, we give salvage chemotherapy, suppress the disease, and then we do autologous transplant so that the disease duration is prolonged. And for leukemias who have got relapsed, for them, we do allogenic transplant. In those cases, autologous transplant is not advisable.
So would you say relapsed or would you say refractory leukemias?
So there are some leukemias which should be transplanted at the very outset. So acute myeloid leukemias, for example, most of them we will say that the moment you go into remission with the first chemotherapy, if you have got a donor, please go ahead and get transplanted. And definitely any acute myeloid leukemia who has relapsed. But not all, but that is an entirely different discussion altogether.
The recent treatments of AML has seen a sea change with chemotherapy, targeted therapies, FLT3 inhibitors. So
Chronic myeloid leukemia at one point of time used to be a major indication for doing a transplant. Nowadays, chronic myeloid leukemia, not more than 5 to 10% of the people actually need a transplant because of targeted therapy like imatinib. So in those cases, we follow them up, and only if they do not have a good response or they develop some mutations, that we need to do a transplant in chronic myeloid leukemia. But when we are coming to you raise the issue of FLT3 inhibitors, for any other targeted therapy, that hype which was there that this targeted therapy could actually work wonders, just like in chronic myeloid leukemia has not happened. Because in chronic myeloid leukemia there is just one mutation which is causing the problem. But in acute myeloid leukemia or acute lymphoblastic leukemia there are more than one mutation. So you have to target a whole lot of genes before you can have some success. That is why it has not worked.
So my last question. So just a word on the tandem transplant and the mini transplant.
So tandem transplant is typically that we are describing for multiple myeloma. So multiple myeloma we do chemotherapy, and then if this person has achieved a complete remission, then we just need to do one transplant. But if that person has not achieved a complete remission, we call it a partial response or a very good partial response. In that case, we do a transplant, then see if that person has gone into CR after the transplant. If not, then we immediately do another transplant within 3 months. So that is called tandem transplant. Tandem transplant is also a term that is used for people who have undergone autologous transplant first, or let us say a lymphoma or a myeloma. And if that person is sufficiently young and fit and has got a match, after the autologous transplant, I can do an allogenic transplant. So that is also called a tandem transplant.
Mini transplant.
So mini transplant, again you use a lower intensity. So all those reduced intensity and other things that are suggested, elderly people or very frail, you can do a mini transplant. It's not actually the term mini transplant. It's a bit of a misnomer. What you're using is chemotherapy at slightly lower doses, with the risk when we are doing this that the chance of relapse is
open to the audience. Dr. Can you give this mic?
One of the issues in our country is the rampant misuse of antibiotics, especially sulfur drugs, and Cetron is one of them. And in 70s and 80s there was a very famous drug called chloramphenicol being misused by practically every GP across the length and breadth of India, and it led to many cases of aplastic anemia. What is the status today of drug-induced aplastic anemia, and is bone marrow transplant a remedy for that?
So bone marrow suppression by drugs is actually very common, and almost all our rheumatology colleagues here would be familiar with it. Wherever they are using methotrexate weekly, or even if you are using azathioprine, some degree of marrow suppression has occurred at some point of time. And the easiest way to manage it is giving chemotherapeutic drugs for so many cancers. They all cause bone marrow suppression. What I am trying to raise the point here is that most of the drugs, the immunosuppression, myelosuppression is actually temporary. I have not yet seen any other like chloramphenicol kind of myelosuppression where the suppression has been completely permanent. Very rare. I have not come across it.
No, I have not come across.
Sir, I would also like to understand from you, and since the drug is not being used very commonly these days, is the bone marrow suppression with chloramphenicol a dose-dependent bone marrow suppression? Is there a critical level beyond which if you start using it? Because I remember when we were doing our internship and house job in 84 and 85, we faced the epidemic of meningococcal meningitis, and chloramphenicol and crystalline penicillin was the drug of choice that we were using. So we were told to use a certain drug of chloramphenicol. What is your take on that? The drug of choice has changed now for meningococcal meningitis, but there are certain indications even for using chloramphenicol even in today's world. So your take on that?
So I last saw chloramphenicol capsule when I was in MBBS. So since that time I have never seen a chloramphenicol capsule. However, having said that, most of the myelosuppression, whatever I read about it, was idiosyncratic. So somebody might not have been exactly overdosed, so it could have been anything. So my take on it is that most of the reactions were idiosyncratic.
More than 12 grams was contraindication.
Sir, last time when you were chairing the session, I asked a question and I will repeat it for everybody's benefit. Two of the commonest causes of aplastic anemia or hypoplastic anemia that we were told when we were doing our MD were post-hepatitis B and post-infections, including typhoid. Is that true even today?
No, sir. In fact, as far as hepatitis is concerned, we have got several cases of aplastic anemia after the hepatitis, and it is neither A, nor B, nor C. And in fact, we call this hepatitis non-A, non-B, non-C. So we don't ever get a cause for the hepatitis. We only know that history-wise there was some jaundice, and subsequently there has been a fall in the blood counts. So the hepatitis has gone. By the time the person comes to us, the jaundice is no longer there, but the marrow does not recover. Post-typhoid again, I have not come across any patient where they have got typhoid. We have had some cases of dengue, but that might have been just incidental. We are staying in a in an endemic area, and somebody had dengue and was going to get aplastic anemia anyway. So I have not got any such case.
Sir, a very far-fetched question, but relevant in today's setting. We are facing dengue epidemic year after year after year, and the mortality keeps changing. And one of the commonest reasons why patients succumb to the disease is severe thrombocytopenia. Is there a role of bone marrow transplant in such conditions?
No, sir. There is no bone marrow failure going on in this case. This is basically a kind of what would you call a serum sickness kind of a picture. Where so even there is no reduction in platelet production within the bone marrow. There is no marrow failure. So, and it is a self-limited problem. So if you just give supportive care, the person is soon going to recover. Transplant is not going to be useful for an infection.
Sir, my last question. I understood from your slides, you said when you prepare donor for bone marrow this thing, is it donor or recipient? So Dr. Sahgal and we were discussing, is it a bone marrow recipient you are preparing or a bone marrow donor with the total irradiation and chemotherapy?
This is the recipient who has to be prepared, because we have to empty the marrow in the recipient, and then you can give the donor stem cells. Also the donor is prepared, because if you are taking marrow, then nothing requires, we just need to anesthetize the person and collect the bone marrow. But we are using stem cells, peripheral stem cells, then you have to give growth factors for 4 days, and on the 5th day we hook them up to the stem cell apheresis machine and we collect the stem cells. But as far as the preparation and conditioning regimen I said, sir, that was for the recipient.
Any aftercare of the donor? Any aftercare of the donor?
No, sir, nothing required. For if you have done a bone marrow harvest, the person is ready to work even from the next day, or if it is a laborer or somebody who works hard, then maybe 7 days. Peripheral blood stem cell, once the collection is done, they can just go back to their work.
Sir, my last question, and a very layman's question. Sir, you said you need to irradiate the bone marrow of the donor, you have to give him very strong chemotherapy because you want to keep the bone.
No, not the donor, only the recipient.
Recipient.
Myelosuppressant.
Now my question is, if you give that and then you transfuse the stem cells, how are they going to react to that chemotherapy and irradiation that you have given?
So the chemotherapy that we are giving are very short-lived. So we give very high doses of chemotherapy, they peak up, they completely ablate the marrow, and then they are all gone away. So by the time we are actually infusing the stem cells, those chemotherapy drugs are already gone. So they are not going to affect the stem cells.
Sir, may I ask? Sir, wonderful talk, and you cleared my doubt about cord cell preservation also. Very recently, I became a grandfather, became a nana. So there was a tussle going on, whom to book for the cord cell preservation, and ultimately it was decided no, none to be. And me and my somebody who is a pediatrician, we decided it's experimental. So I thank you for clearing my doubt, sir. Sir, my first question is, what is about gene therapy? Gene therapy.
So gene therapy currently is there for a few conditions as far as hematology is concerned in hemophilia, and it is coming up slowly in thalassemia. Again, even for gene therapy also, you have to have a viral vector You have to synthesize that particular DNA within that viral vector and then inject that into the person who has got the problem. Again, the whole process is like a transplant. You have to first ablate the person, you have to remove the marrow and then inject it. So gene therapy right now is showing promise. It has been showing promise for several years, but only now in one or two conditions it has started to show some benefit.
What I read about it was very costly.
Yes, it is very costly, but then it is only useful for one or two cases. Like even in hemophilia, the gene therapy that is done does not help in completely, completely replacing all your factor. The person might, that gene therapy with the cells that you inject, it might just bring out some percentage, but not completely.
I have a few patients of thalassemia major. So what is the age factor that you will decide for the whether to give or not to give bone marrow transplant? Because I have 2-3 ready patients, but I think they are not up to that age. What is the upper limit?
So the upper limit, there is no lower or upper limit. You can even take a 2-year-old child for a thalassemia transplant if they have a donor, and that would be a very good age to take up for a transplant more than 2 years, because already the bones have developed, and then there are also the side effects of blood transfusion are not there, so they can be taken up for a transplant if there is a match.
My patient is 30 years old.
30 years old. Now that is the problem. So one moment you have crossed 7-year-old, 9-year-old, and they have been transfused heavily, all the side effects of iron overload are there. Either the heart is damaged or the liver is damaged, and these people will simply die if you try to do a transplant.
So in the post-transplant, you said the acyclovir was one of the medicine to be given. Is acyclovir, it was very old medicine.
Yes.
Can famciclovir or the newer medicine less frequently given? Say acyclovir is given 5 hourly.
No, we just give it as a prophylaxis twice a day. 400 milligram twice a day.
Okay.
It is just a prophylactic dose.
It's not the full dose.
No, no.
Okay, sir. Thank you so much.
So what is the
During bone marrow aspiration, you said putting a needle inside is not painful. But during aspiration, patient feels.
So I was just trying to describe what a transplant procedure, when we do a bone marrow aspiration or biopsy for routine testing, this has been our observation. Because we are able to anesthetize the whole tract, the skin tract, we are also able to anesthetize the periosteum. But we cannot go into the bone, you see. And then the moment we put the needle inside and then we aspirate, patients complain of that severe pain which they have.
You said putting a needle is not painful.
No, because we are able to anesthetize up to the periosteum. So that is, if you are properly anesthetized, then the person should not feel a pain when you are actually piercing. It's only after going into the marrow where anesthesia is not existing.
Sir, actually, what is the mortality during induction therapy? What is the mortality while doing bone marrow transplant? Because I found 2 patients of AML. They were 60, 61. One was lost within 6 days of induction chemotherapy. The other one was lost within a week of bone marrow transplant.
So again, that is a lot.
And what is the success rate during this procedure?
So that is what I was trying to say. The last question I put up, that the success rate differs from person to person and even within the same indication. That 60-year-old, I cannot answer you directly. It might have been that he had other comorbidities. Maybe that person who went for the induction chemotherapy had pneumonia or some infection. I do not know, because within 5 to 6 days, that means that person was already infected, or maybe some kind of comorbidity was there.
So you were well investigated.
Well investigated.
Yeah.
So I cannot answer that question straight away.
No, I'm just telling that I came across 2 patients of AML. They were 60, 61, both were lost.
Yeah.
And second is the cost which you were telling. They are AIMS cost or the at max?
So so these are the max costs. So AIMS cost would be about 30% lesser. But again, one should not get worried of this 1 or 2 anecdotal reports of death ho gaya. So that should not worry a person. For example, we have got many transplanters who do transplant. Maybe they have done 10 transplants. All of them are surviving. They say we have got 100% results. So that is also not correct. At the same time, if you have 2 deaths,
I just came across 2.
Two.
Depends on the center of
People
center.
will fare
yes.
One was
Younger
AIMS, one was
people
Manipal.
So younger people will fare better.
Yeah,
However, again, it is depending upon your physical and mental fitness, which is more important.
They are very rigid about the age, 59 and 60. The mortality is very high between the 2.
Between above 60, the mortality, induction mortality, and other things start to increase. But nowadays we are also getting, so we have to choose patients also. Somebody who has to be very fit, who has to be very, so one of the very easy tools is doing an ECOG, performance score. That 0, 1, 2, 3, 4. Like 0 is somebody like us, completely mobile. 1 is so that is
They were all
actually
first class score.
first class people.
So my question is, like you have rejection with every transplant, kidney transplant, liver transplant. So there would be certain percentage which would be going into rejection. Number one. Number two, so imagine there's a guy who needs a transplant at the age of 55 and he doesn't get a donor and the only donor will be his wife. So do you prepare the wife the same way like you do in the kidney transplant?
Like a wife will never be a transplant donor for a bone marrow transplant because
doing a thalassemia screening program.
sir.
We are doing, all the centers are doing Nestrop test, and when it comes positive, they are sent to either Hinduda or one of our center which is doing electrophoresis.
Yes.
When the test comes positive for thalassemia, we practically advise for abortion.
Oh, okay.
So in the light of bone marrow transplant, what should be the recommendation?
No, I think that would be very wrong to say that if somebody has got thalassemia trait, basically you're talking of a mother who has come to you with a pregnancy and you find that thalassemia trait, you say that you abort. I think that should not be the correct way. You should first look at the husband. If the husband is normal, then this child at worst will be a trait. So usko kuch problem nahi hone wala. So why should you want to abort? And secondly, if that person has, even if the father and the mother both are trait, there is a likelihood that this person could have a thalassemia in the child. You do chorionic villus sampling, you send them to AIMS, you send them to RML, you do chorionic villus sampling and see if the child is thalassemic or not.
Suppose it is major.
If it is minor, then there is no problem.
There is no problem.
Say it is major.
Yes.
Fetus is major.
Yes.
What to do?
So that is then the choice of the parents. So,
What should be the cost of transplant?
sir?
What should be the cost of transplant when we advise for transplant?
Okay, cost of transplant. So cost of transplant again varies from indication to indication. So if you are only talking of thalassemia, it ranges between 10 to 15 lakhs depending upon the center and age of the child. So it can be done within 10 also if there are no complications. I usually tell people it will be within 10 to 15.
Dr. Saigal.
Sir, three small questions. One is regarding this only. In thalassemia major, what are the outcomes of transplant? Number one. Number two, what about the vaccination? In person who has been transplanted, you advise vaccination as a small child,
Yes.
Do we give live vaccine in such patient or not? Or if at all we give live vaccine, like you said, MMR and all that, when do we start then? Number two. And number three, what is the indication of doing transplant in multiple myeloma?
So first the vaccine part, we only use killed vaccines. So even for polio that we are using, we use the inactivated polio ITD. So we don't use oral polio. And also we advise the family that in their own family, any child is there, they should not be getting oral polio if there is a transplant present in that family.
Or we should avoid contact with the person for quite some time.
Yes. And then your first question was success rates of thalassemia transplant. In fact, that was what I raised at the last slide. Even within the thalassemic population, there is a heterogeneous group. So if somebody is say 30-year-old, like Dr. Saab said, I will not touch that person. Somebody who is not even 12-year-old with enlarged liver fibrosis, heart disease, or never been properly iron chelated, that is called class 3. And that class 3, the success rates are not more than 57%. But if you take a class 1, well chelated, no iron overload, and no hepatomegaly, 85 to 90% success rates. And then finally you said about myeloma. Yes, today the standard of care for somebody who is transplant eligible means somebody who is up till 65 years of age. For them the standard of care is chemotherapy, 3 cycles followed by autologous stem cell transplant. In here this is not actually transplant, it is actually high dose chemotherapy because your own cells are used to replace it.
How successful is this, in these patients?
Yes, so the median duration of improvement of survival, disease-free survival is as high as 20 to 24 months. So when I say median survival means there is always a bell-shaped curve. So we try to tell them that normally after doing a transplant for myeloma compared to somebody who has not been transplanted, you will have 4 more years of disease-free interval.
Last patient, Dr. Kapoor.
Could you talk about myelosclerosis? Can we use it in that?
Myelofibrosis. And sclerosis, osteopetrosis and osteosclerosis, yes. Myelosclerosis. So myelosclerosis means again either fibrosis or it is replaced by something else.
Okay, or fat.
Yes, so depends upon, so myelofibrosis, yes, it would be.
We can use it?
But not for somebody who's say, let's say fluorosis. उसमें भी sclerosis होगा, तो that will not help with transplant.
Thank you.
Sir, a small follow-up question. After 5 years of transplant, can we give live vaccines? Or after 3 years or 4 years or 2 years?
Dr. Sehgal, I would request you to ask the questions at later time. We need to wind up now really. Thank you so much Dr. Pravas Mishra. Thank you so much Dr. for sharing your session. And thank you so much Untitled Oncology to sponsor this meet for us. I hope you found the CME to be up to the mark. And sir, thank you so much. First, Dr. M.L. Kalra to step forward to introduce me to Dr. Pravas Mishra, a wonderful person. He is the first chairperson who was trying to fix our Physician Forum of India emblem last time 2 times. He would get up from his chair, try to fix the. This is the first gentleman I have seen in my life to do it. Sir, you are a person who needs to be emulated, and you are absolutely humble. So we are grateful that you are a part of this forum. I would request Dr. M.L. Kalra to honor sir. I would now request you to join for a dinner.